Okay. Yes, Camille, it is okay. Hello, everyone, as I speak slowly, as everyone comes out of the waiting room and into this webinar that we have this afternoon, this morning, or this evening, wherever you are positioned around the world. Um, my name is Eric Sutherland. I'm a senior health economist at the Organization for Economic Cooperation and Development. My focus is at the intersection of all things digital and all things health. And in particular, we have been working on this report that was published this week in cooperation with the World Medical Association on the perceptions of medical associations related to the application of artificial intelligence in health. And so I think it's a extraordinarily timely and topical subject. And we have four fantastic panelists that are joining us today. But I'm going to start the discussion by turning over some opening remarks to Stefano Scarpetti, who is the Director for Employment, Labor, and Social Services, which includes the Health Division at the OECD. So over to you, Stefano, for some opening remarks.
Thank you. Thank you very much, Eric. And indeed, good morning, good afternoon, good evening, wherever you are. And a warm welcome to this panel on perception of artificial intelligence for medical association. I think we all agree that the healthcare has already advanced through medical and technological innovation for a number of years. And this, no doubt, has a strong positive impact on life expectancy as well as on care quality. In the post-pandemic era, this transformation actually has accelerated, but we also see a number of growing challenges, such as the heightened demand for healthcare services, the aging of the population in many OECD countries, the soaring cost of health, and an overburdened workforce, with at the same time evolving expectations, which are putting additional pressure on healthcare systems just around the world. In this context, I think there is no question that artificial intelligence is unlocking new potential opportunities for the healthcare systems, including by streamlining health-related activities. There are a number of examples on that. Text-to-speech models can reduce nurses' workload and provide accurate and timely health information. AI-enabled precision and alerts in diagnosis and drug interactions can also contribute to save time and actually lives while reducing at the same time cost. AI can also contribute to operational efficiency as it will free up valuable time which can allow healthcare professionals to dedicate more time to patient care and ultimately improve the health outcomes. The report based on from the European data suggests that up to 30% of all the administrative tasks in healthcare can actually be automated already by 2030. AI can also play a significant role in the discovery and in the development of new treatment. But while these benefits are likely to grow as the capabilities, trust, and the evidence base develop in artificial intelligence, there are also a number of significant challenges that we have to consider. Weak digital and data infrastructures, inconsistent health data governance, inadequate technology standards, and also limited resources can limit the potential of AI to do good in the health sector. The risk to patients, such as biased algorithms that can adversely affect care and access to, or actually increase the cost of insurance. So the need for healthcare providers to learn new skills and adapt the work of some of their tasks are actually automated. So this is the backdrop, and against this backdrop, the OECD, in collaboration with the World Medical Association, surveyed 18 medical associations across the world to better understand the perspective of healthcare professionals on integrating artificial intelligence tools into their routine care. The findings, I think, offer valuable insights into the significance of artificial intelligence development in shaping the future of the healthcare. Let me just highlight a few of the emerging results from this work. First, healthcare providers are not worried about artificial intelligence replacing their job, with actually 70% of them indicating that the role of physicians will remain indeed central. This is actually consistent with the findings we had on our broader surveys covering 2,000 companies and 5,300 workers in OECD countries, where so far there is no evidence that artificial intelligence is replacing workers in just about all the sectors for which we have evidence. Healthcare providers are, however, worried about AI being designed and implemented without them. The second point is that 72% of the medical associations surveyed believe that the benefit of artificial intelligence in healthcare will outweigh the possible risks. However, ethical concern and liability are major challenges. 94% of the respondents expressed worries about ethical issues that may arise from AI application in medical practice. And 71% believe that physicians' liability will increase due to their use of artificial intelligence solutions when those solutions are actually incorrect. Third, the survey shows that 74% of the medical association identified data accessibility and the operational infrastructure as significant barriers to the adoption of artificial intelligence. These findings from the survey suggest a number of priorities to promote a trustworthy adoption of artificial intelligence in healthcare. And these include upskilling and updating the curricula of the health professional to meet evolving digital needs, which are essential to empower them to actually perform better with artificial intelligence. Engaging healthcare professionals in the design, but actually in the implementation and adoption of AI tools, respecting with their need, but also taking into account their expertise. Third, establishing internal units and leadership positions to coordinate and to manage application in AI applications. Leveraging the expertise from other AI leading industries, such as, for example, finance and consumer goods, to understand emerging trends and how to maximize the skill use. All in all, these results, I think, confirm that indeed artificial intelligence could provide a meaningful contribution to improve healthcare and address the shortage of about 3 million health professionals projected by 2030 just in the OECD countries. But for this to happen, we need to have measures in place to strike the balance between sizing the opportunities of AI and putting safeguards in place. And we need to implement these measures with the contribution of the health providers. With these few remarks, let me now pass the floor back to Eric, who actually will drill down onto some of the more detailed results from this very interesting and very innovative survey. Eric, over to you.
Thank you very, very much, Stefano. I think that is, it demonstrates the relevance of the findings and the practical implications of some of these findings in terms of the various actions that leaders can take around the world. Like this survey overall, it presents various fascinating touch points that can serve as a foundation for overall today's discussion and future conversations on integrating AI into routine care. It highlights a crucial role of the health workforce as a catalyst in collaborating and ensuring the effective introduction of advanced technologies. The survey itself covered a wide range of topics from general perceptions, looking at the opportunities and the risks. And the World Medical Association was a fantastic partner, both in reviewing and understanding the survey and connecting us with many medical associations around the world who contributed their responses and provided their insights. Overall, big picture issues are really AI. The perceptions are that AI is the benefits of it outweighs the risks. But there are risks that must be understood and appropriately managed. There are programs that are in place should really prioritize how can we actually act and enable the use of AI while at the same time managing those risks. And one of the important areas that comes out is that the workforce productivity, improving the experience for health providers is paramount in this. As there are two great quotes that we got through this work. One, that health providers are not worried about AI replacing their jobs, but they are worried about AI being dropped in their desks in a way that they don't understand. So, in other words, how can we actually make sure that AI solutions are developed with health providers, not to health providers? Because that will both improve the efficacy of those solutions as well as the adoption of those solutions. And then another participant remarked that we're not worried about AI replacing our jobs as doctors, but practically, doctors who use AI effectively will replace doctors who do not use AI. And so I think that that is serves as sober reflection in this space, certainly. We already heard a bunch of statistics that almost half of the respondents reinforce that previous work supports the idea that AI is going to act as an advisor and assistant. It's not going to replace. It's really augmenting the capabilities of our doctors, especially for administrative tasks. I reflect that in the Netherlands, they have a strategic view to reduce administrative workload for health providers by 50% through a combination of artificial intelligence and reduction of red tape. And I think that is a bold goal that they have, and one that I think that many countries could also examine for themselves. So, with all that said, ultimately, the survey really identifies what are the steps that are needed to ensure that AI is adopted securely and used for the public benefit. As mentioned earlier, there are three recommendations around the upskilling of health professionals, investing in frontline AI solutions, and involving health professionals in the full AI lifecycle. That I think is really, really crucial. In terms of the work that we're doing today, as I said, we're joined by various panelists so everyone knows this webinar is being recorded, is in fact being live streamed on YouTube as we speak. And as you can see, we have nearing 200 different attendees, which is more than fantastic. If you do have questions during the discussion, please use the Q&A function, and we will reply to the question where we can, or put in questions in there for our panels that we may come to during the discussion. But with all that said, I'm going to start by introducing our esteemed panel for today. In the of our four panelists that we have, I'd first like to introduce the gentleman who is the instigator and author of this survey, Dr. Nachman Ash, who's a medical doctor who worked at the OECD for a period of time last year, having previously served as the Director General of the Ministry of Health in Israel. We also have Dr. Giovanni Briganti, medical doctor and the chair of the AI and Digital Medicine at the Université de Mons, and also an author of the AI Barometer Survey in Belgium. From admittedly quite early for Dr. Jesse Ehrenfeld, who is a medical doctor and president of the American Medical Association and professor of anesthesiology at the Medical College of Wisconsin. And we also have Dr. Muzu Nodika, who's CEO of the South African Medical Association. So it is fantastic having all of our panelists here today, and I'm really excited by the discussion. And without further ado, I'm going to get on with the panel discussion. So the first question I am going to ask to you, Nachman, as the ultimate author of this report and the inspiration for having done this work in the first place, how would you describe the adoption of AI within the Israeli health system during and after COVID-19? And what do you perceive were the lessons learned that are being addressed today?
Hello, everybody, and thank you, Eric, for this question. And I would like to use this opportunity and to thank you and our co-authors for really leading this work and collaborating with the World Medical Association. It was a great time in the OECD. There is a lot of enthusiasm around AI application in our healthcare system, and there are many initiatives to develop and implement such application. Most of them are bottom-up initiatives by startup companies and healthcare workers, and these are adopted by health organizations like HMOs and hospitals. But there's also a top-down process that I'll describe in a minute. To mention a few examples, AI Doc is a system that uses AI to assist radiologists in evaluating radiology tests and is implemented in some hospitals. IBEX is a company that developed the digital pathology AI-based evaluation that is implemented in one of the HMOs in Israel. It is mentioned in our report. Another HMO developed and implemented a system called CPI. It is a risk assessment system in primary care. It is aimed to give the physician a list of patients at risk in some fields like diabetes. And I would like also to mention that there are many initiatives in mental health as the need is growing rapidly after the COVID-19 outbreak. The top-down process is based on governmental support of initiatives that are selected by various criteria. Those initiatives that seem to be more meaningful by their impact on clinical care and at the same time less risky are funded and followed by the Ministry of Health. For example, the Ministry of Health supported the implementation of an application that helps to schedule treatments in a rehabilitation center, so the burden of planning treatment sessions is taken from the caregivers. In most cases, the applications are used for decision support that improves quality of care. Thus, they create a new work environment for the clinician. The main benefits rest on possible quality improvement, but this is yet to be proven. One of our HMOs, Clalit, showed the efficiency of risk assessment during the COVID-19 pandemic and also in hepatitis C screening, also reducing the load on caregivers that had to do this screening. Unfortunately, we can't yet show any impact on health workforce, and definitely not by reducing the burden and burnout. I hope that this will turn in the next years. As for the lessons learned, I would like to emphasize the importance of creating a national environment that encourages development and implementation of AI application, but leads the path. So efforts are invested in solutions that deal with challenges like reducing burden and improving quality of care. Thank you.
Thank you. That is extraordinary, the work that's been done, covering a wide range of clinical practice, medical health, acting as decision support assistants. I think one of the major reflections I get from that is that this is creating a new working environment. And in that new working environment, it is meaningfully helping in some ways, reducing workload. But there are other areas where it is maybe not increasing, but certainly changing workload significantly. And maybe that is one of the major lessons from this work is that there is change. And if we want to take advantage of these opportunities, we need to think about how to adapt and manage that change going forward. So thank you for that. That's really fascinating. Let me go to you, Giovanni. I see that. Hope that your Wi-Fi issues were sorted out. In terms of your the landscape within Belgium right now, we had the pleasure of giving a talk up in Antwerp back in the end of September and talked about a bunch of work that they're doing there in their innovation hub. But I'm curious, in a broader perspective of what's happening in AI, what is the current landscape there within Belgium today?
Thank you, Eric, and I quite appreciate you inviting me on this panel, and I quite appreciated reading the work that you have been doing at the OECD with the current study with the AI and healthcare professionals. Now, in Belgium, the landscape is quite particular because such a small country, Belgium, 11 million people, but a really vibrant ecosystem from all different aspects. We have only from the French-speaking part of Belgium more than 700 researchers that do research on AI, and among them, a third does at least research in AI and health. So this means that we have a very strong research background in Belgium, even if it is a small country. We have a very vibrant economic ecosystem with more than 300 SMEs that do that have AI, digital health as a main topic of development. We were the first to conduct a nationwide survey on the adoption of AI in medical professionals from a national point of view. And we studied that on specialist doctors, in general practitioners, but also we studied that in other professions as well. We studied the emergency department, the pharmaceutical industry, and now we are finishing up a nursing barometer. The main results is that overall Belgium stays a kind of special place in which medical doctors are quite positive towards AI development. This is what well exits out of our studies, but it is not without reasons that we are a kind of special country when it comes to that. Education-wise, we have also been the first, including mandatory AI education in medical curriculum at the University of Mons, and it is now spreading out in other different universities when it comes. And so basic education has been provided with mandatory AI programs. We are also including that into ongoing education, the education programs that are offered with the medical doctors that are already practicing doctors that need some more ongoing education to be educated. Overall, all political and governmental entities are interested and have included AI and health as a part of their strategy. And this is what makes Belgium such at the forefront of AI development. But the main reason I would still once again stress out is education. We have been able to install these different education platforms, both within as mandatory education with the basic medical education, and we are strengthening that in ongoing medical education. So that's it for me, just to present to you the landscape in Belgium. And we have a national working group called AI for Health that I have been leading since 2020, whose role is to inform well, different political cabinets on the strategies to uptake with AI.
That is fantastic. I would like to dig into what that group has as its priorities, but we'll worry about that in a subsequent round of discussions. I think that would be really interesting for the group. But I'll now hop across the pond, so to speak, over to the United States and ask you, Jesse, from the perspective, like the United States has been in many ways a leader in the AI revolution with massive amounts of innovation happening across multiple industries, with many of the larger AI players coming from the US. So I'm curious how that is interacting with the evolution of AI, specifically in health in the US, from your perspective at the AMA.
Well, Eric, thank you so much for including the AMA in this really fascinating conversation. This is something that we think a lot about and is on the top of our minds. It's clear, given the tremendous workforce pressures. So we have 83 million Americans today that do not have adequate access to primary care. In a country of 335 million people, there is a clear need to rely on these tools to scale the capacity of the health workforce if we're going to be successful in delivering the kind of care that we want to for all Americans. So I'd say that physicians really understand the potential for new digital tools, AI-enabled algorithms, to help address the growing healthcare needs, as well as eliminate some of the disparities in how care is delivered across the nation, while trying to streamline our workflows and make it easier to work across the delivery system. What our survey work shows internally is that we continue to see more and more adoption of these tools, and it's grown markedly in the last 5 years. This is true amongst all physicians, regardless of their gender, their specialty, or their age. In fact, physicians over 50 are among the largest areas of growth for all of these tools. So despite a lot of the questions about liability, the evidence that should be required for algorithms to be brought into the marketplace, payment, implementation, usability, despite all of those questions, nearly 1 in 5 physicians today in the US are using AI tools in their practices, in their systems, in their hospitals. Most of those applications are around back office practice efficiency work. And what we're starting to see is more and more clinical applications come to bear. Certainly, there's been tremendous uptake in image recognition, radiology, gastroenterology, other image heavy specialties where algorithms have found tremendous opportunity to backstop and add reliability to what the human in the loop, the physician, is providing. So that all being said, about 4 in 10 US physicians today is equally excited as they are terrified about what this will mean for the future. And while people see the clinical applications, they see the need, they see the opportunity to scale up the capacity of our healthcare teams, they worry about bias. They worry about what happens to my relationship with my patient when there's an automatic tool that might be at that interface. And so I think there's a lot of excitement. We're seeing widespread adoption of things like ambient dictation technologies, so that when I walk into a clinic room, I talk to my patient and I walk out, my note is automatically generated. Those tools are becoming ubiquitous. There are dozens of companies that have brought products into the marketplace. And those things, while they may not impact the patient's care directly, they're so important from a workflow standpoint because it gives clinicians hours and hours and hours back of their time each and every week and every month when those kinds of tools are implemented. So a lot happening in the US. Really excited to be a part of this conversation, and thanks for having me.
1 in 5 are using AI today. That is, I don't know if other countries would be jealous of that or not, but I think that just certainly demonstrates that this is, how can I say it, not just hype. This is something that is real. It is being applied. It is helping medical practitioners today. And we do have to be cautious about using it in areas such as you talk about bias. And I really like the comment about how does this change my relationship with the patient. And in a way that reflects back on what Nachman was saying at the outset around the work is shifting. Work is going to be different with AI, but how is it going to be different? We're still working that out. So I think that's really, really, really interesting. Thank you for that. And with that, I'm going to move back across the pond, but go south, down to South Africa, and Dr. Nodikita Ruzo. And I think for many of our conversations around AI, admittedly, certainly being in the OECD, focuses on many of the countries that are actively doing things from the OECD's perspective in Europe and in North America and South America, et cetera. But the OECD has no countries in South America and Africa at all, let alone Africa. So I'm very, very curious about what is the current landscape in South Africa right now, and what are you most excited by in terms of AI as it moves forward?
No, thank you very much, Eric, and I must really appreciate the opportunity that you've given to the South African Medical Association to be part of this webinar. Well, in South Africa, the landscape is both promising in terms of development, but we do have significant challenges as well. So South Africa is leveraging AI in specific healthcare applications, mainly in diagnostics, medical imaging. We also using it a lot in terms of patient data management. We use a lot of algorithms in radiology and in pathology to detect diseases early, with high accuracy as well. So we're making a lot of strides in terms of using AI in predictive analytics, such as forecasting potential disease outbreaks. We do also use it in assessing patient risk factors. But this is mainly in the affluent areas of the country. And in South Africa, we medical training is concentrated in the public sector, and the training hospitals would then be referred to as central hospitals. And in the main, they are in the cities. There's quite a few that are in rural areas. And those hospitals would have the necessary infrastructure. But in the main, the application happens within the private sector. So there is that urban rural divide in terms of the infrastructure, and that kind of affects presents like a barrier in terms of the implementation of some of these AI solutions. The other thing that I think for our country is a little bit complicates the landscape even further are issues that relate to data privacy and the regulatory concerns. Our country has got an act that protects personal information. It's called the POPIA. And this act, as it is today, kind of limits the use of patient data. And we all know that machine learning needs quite a vast amount of patient data to be able to develop these algorithms. So there is a growing need for an AI-specific regulation that addresses not only data protection, but also deals with the ethical issues in AI. So in terms of the potential, we believe as some that there's a significant potential for AI implementation to be impactful in healthcare, especially if it's applied properly with proper clinical leadership, which is one thing that we really are looking for, especially if we're focusing on automating some of the routine processes. I mean, in practices, doctors spend a lot of time consulting the patient, which could be done by an AI tool that could then let the doctor just delve into the most patient-centered issues that they can deal with. So I think one of the is burdening the health system in South Africa is it relates to medical legal claims. And in one of the symposiums that the country had about 3 years ago was that South Africa needs what we call a universal health record with integrated system that then houses the data, so that it becomes easy to access this information, even for precision medicine, when we do get to the universal health coverage phase. So we are excited as a country, and we do think that as an association, we're actually hosting an AI roundtable, AI in healthcare roundtable on the 28th and the 29th of November. So this is next week, Thursday and Friday. And we will have Jess there speaking as one of our keynote speakers. So we really are looking at developing the critical mass in terms of doctors being trained in AI in healthcare, so that the results of the study can actually be applicable in our setting as well, and we take the fear of being replaced by AI away from the doctor. So thank you very much.
I love that last comment in particular, that what can we do to, I'll use the word demystify, to take the fear away of what AI is. And as I've often say, AI is not magic, it is math. And so how can we actually leverage AI for good in a way that we actually understand it? And I really enjoy what you're talking about in terms of the importance of clinical leadership and the importance of our data foundations, respecting privacy and the protections that are around. As I like to say, AI without data is like taps without water. You need both. And in many ways, if you don't have a strong data foundation, your ability to get value out of your AI algorithms are going to be really, really challenging. So thank you for highlighting all of those areas. So with that said, I see that we already have some great questions coming through the chat. What I'm going to do is go through another round of questions with the panel, then I'll probably do questions from the chat, and then I'll mix it up back and forth a little bit. But I'll turn back to you, Nachman. And reflect in some of the word from Israel that and also from your broader perspective, having worked with everybody on this paper, that many medical associations on the theme of data view data accessibility as a significant obstacle, particularly for properly training various AI algorithms. As both a medical doctor and as the leader of the study, do you believe that this perspective can impact the trust within the workforce and the effectiveness of our AI solutions?
Well, trust is a major factor in influencing the adoption of any technology by caregivers, and especially AI. And actually, I think we can say that implementation of AI in health will move at the speed of trust. If we gain more trust, we can move with AI. Accessibility of data is a challenge all over the world. I'm sure that everybody here agrees with that. And indeed, this concern was, as you said, raised by most medical associations. We usually see challenges of data accessibility as an obstacle to developing AI applications, since we don't have access to data. And for example, one of our interviewees told us that he may spend few months organizing data, and in contrast, only few days developing the algorithm. And that says everything about the data. So how is data accessibility linked to trust? If the data to train the AI application is not available, it might have impact on the accuracy and fairness of the application. And this is a crucial obstacle to gain providers' trust. Quality of care is obviously very important for both physicians and patients. Physicians may not trust technology that seems to them inaccurate or not appropriate for the whole spectrum of the patients. And accuracy and fairness are dependent on data availability to train AI application. If some of the data is missing, and particularly if the missing data concentrates in certain populations, women, for example, the application might be biased. Therefore, training on large and viable samples ensures quality, reliability, and equality. We all know that. So governments should make data accessible to enable state-of-the-art training of AI applications. It is important for many reasons, but also for building trust among physicians who are using this application. I would like to emphasize that the obstacles in data availability are not only the result of privacy concern and data standardization, but are related sometimes to organizations that are not willing to share data for various reasons and to failure to see the common good in sharing health information. So governments should deal with this issue as well. Thank you.
I apologize for coughing over the last part. Yeah, absolutely. In an interview I gave a little while ago, reflecting on AI, I was suggesting that focusing on culture first, followed by strengthening data foundations, and then trying to drive your AI solutions makes sense. That if you started AI without having a cultural foundation of collaboration across organizations, nor a good data foundation, it's going to be really challenging. So, and I love the quote of moving at the speed of trust. I think that is something that many of us can take to our hearts, because it's something that is earned not given. So how can we actually do that more meaningfully across the organizations? That's fantastic. With that, I will shift to Giovanni. And so, as promised, I'm curious about the work of your group that you have in Belgium and reflecting um, that in the paper it talked about health professionals are worried about AI being developed without them, but not with AI as a solution, but also that the integration of AI into practices have led to practical complications, worries about ethics or reimbursement and or liability. So from your perspective as a doctor, as a researcher, what do you think of as the critical steps to ensure smooth introduction of AI into the clinical settings? And are there any other areas that your working group is particularly worried about that are being practically addressed?
Thank you, Eric. The question is quite complex. I will try to outline several points. Trust is not enough because trust is earned, but to earn trust, there is a kind of methodology to earn that trust. And several points will make it so that clinical professionals will kind of adopt AI in clinical practice because they feel they are safe while doing it. Not only the professionals, but also the patients, of course. Some points. First, we are probably headed towards an AI replication crisis because most papers that are published in the literature they fail to replicate in other examples, for instance, in other cities or other countries, other population, other sample populations that are different than the ones that the algorithms were trained on. Recent meta-analysis, in fact, showed that the vast majority of AI papers in the literature do not have a safe design. And therefore, we need to push back some kind of a biostatistical research methodological agenda back in the AI development. And this is a first step in ensuring that the physicians can actually have at their disposal trustworthy documents, numbers, performance issues that can help them make choices. Of course, professionals are not educated to AI. Most of them are not, and therefore they cannot validate themselves and assess themselves new technology. National bodies need to become competent and responsible for assessing solutions that might be applied in one specific country, and therefore taking back the responsibility from the clinician, because as long as the clinician will be legally responsible to validate, to evaluate the technology, that is, of course, one major problem, that is withholding adoption. Another problem is how to do adoption, even if a model works well. Many studies have showed how the added value for patients is quite low. Because while adopting a model, even though the model works well, the way that, for one, notification occur, two, patients are taken in charge, three, how the outcomes are measured, we cannot have a practical difference that is measured when assessing the patient's outcome. Another problem that is withholding AI adoption is this current obsession of replacing the physician with machines. Most studies, because they are competing, they're making compete medical doctors, artificial intelligence, because they're simply doing a validation comparison. They are kind of scaring the physicians that are in the domain. And sometimes the comparison is not even fair. There are studies out there that compare empathy of physicians versus general artificial intelligence. This does not make sense from an epistemological point of view to study the empathy of a machine that cannot feel empathy in any case. Another factor I would like to mention that is withholding adoption in clinical practice is financing. Many countries have different policies in reimbursing AI in health and digital health solutions. In Belgium, like many other countries, we are evaluating financing models, but it is quite shy at the moment. And this is a major concern because many hospitals cannot take in charge themselves given solutions to deploy with patients, and patients cannot themselves pay for solutions that they will follow up in time. So financing problems are also another problem. Another issue I will mention is a language problem when speaking to the stakeholders. Industry partners will have much more short-sighted, conditions and visions to obtain data, to better reimburse medication, to better reimburse technology. But the hospitals and medical doctors, they will have long-term goals while really innovating and implementing AI in the long term. And therefore, pilot projects in AI are just not working because they run 24 months. And then the hospital either has to refinance the project themselves or find for other external financing. Because there is no structural way of supporting these projects, they are being interrupted. And when we interrupt one AI project, I always say that the next 5 will be thoroughly compromised because they will have cost any organization an amazing amount of time. So these are just a few obstacles. I will just conclude with one additional obstacle is the societal reflection and thinking about how we are going to implement AI in clinical practice, predict several points, such as how we will replace the time that will be earned with these technology. And I end here.
That was a lot. And for all of the hope that I have with AI, I certainly trust that the audience has got a very good sense now about this is why it is really hard. And it's really hard to build AI solutions that actually have broad-based scalability. We tend to incent pilot solutions that don't end up going anywhere. But as you said, from a medical practitioner perspective, we want the solutions that can actually scale in a meaningful way. And that's where things like financial models, updating the research agenda, and really being clear about that longer term vision that we actually have is shared more broadly across the whole community. I think those are all important lessons. From your perspective, Jesse, when you're thinking about the health policies and investments, especially in a world where where 1 out of 5 doctors are using AI systems, what do you think are some of the lessons we can learn from their experiences, why they feel safe using those solutions, and what are other things we can do in order to help medical practitioners feel safe using AI solutions?
Yeah, so you've got to remember that the majority of the use is in back-end, non-patient facing activities, supply chain, scheduling, ambient dictation. The clinical solutions are coming online, but they're point solutions, they're not platforms. And to a previous point that Giovanni was making, one of the big challenges we're having is no chief medical information officer or CIO wants to implement 100 different tools from 30 different vendors. That's impossible. One large center, household name that you would all know, told me that they spent $3 million doing implementation, evaluation, and validation of one AI product. $3 million. One center, one hospital, one part of the country. There's no way to scale that, right? So until we move to a platform approach where we have tools that can link and we can solve this sort of validation problem at scale, performance monitoring over time, we're going to be very limited in terms of the actual uptake across populations. That being said, we've got to maintain trust. We've got to make sure that the tools work. And our biggest problem right now is we don't have a regulatory framework that actually allows us to make sure that tools are safe and effective. The FDA's framework set up in the 60s and 70s for medications and biologics and medical devices does not hold up for AI digital tools. We all recognize that. You could never hire enough product reviewers to look at each algorithm and software change in a traditional manner. So we have to pivot in some way, but nobody really understands what level of evidence ought to be required before a clinical tool is brought into practice. The last thing I'll just say in terms of making sure that these things work is we've got to have transparency. Transparency is not explainability. Explainability is difficult, right? And that's, knowing what the machine is doing. But transparency means that when I walk into an operating room and I turn on a ventilator and there's an AI algorithm trying to modulate, optimize my inflation pressures, I've got to know that there's an algorithm doing something. The only way that I can be the human in the loop, the final backstop to make sure that my patient is not harmed, is if I know the system's there. And the lesson here comes from actually the aviation industry, where Boeing made a tragic mistake when they put in the 737 MAX an AI control system that nobody knew about, right? And when there was a sensor malfunction and these poor pilots on those doomed airliners, right, saw their lives lost. We simply cannot allow transparency to not exist in healthcare. It's too important. And we're obviously trying to figure out how do we regulate that in a way that allows innovation, but also ensures safety.
Awesome. And I think that, as you said, really reflects some of the things that Giovanni was saying before as well about the need, even from a clinical research perspective, to actually revisit how we can actually embed in the requirements of these studies that are coming out the requirements that would allow somebody to trust the solutions, because we have this replication crisis that's actually happening, let alone the regulatory landscape. One of my reflections is that we will have in short order more AI applications than drugs, and yet our ability to keep up with drug certification is a challenge. And so, how do we actually keep up with the pace of change? It's hard, and we have to rethink solutions. And I think that's going to be one of the next great challenges that we have to undertake in this space. Having said that, we'll save that last part for later on. And I do appreciate it. I think we're starting to answer some of the questions that are coming up in the chat, so you guys know. Ahmed talked about what AI tools are practically used nowadays. I think a large part of what you're talking about, Jesse, used a lot of the ambient back office type functions, less so in the clinical areas. Why? Because the clinical areas are challenging for all the reasons we've just heard about in the last few areas. Although there are some areas where clinical solutions are actually coming up. So I think that there are opportunities in this space, but we have a lot of caution in that space, justifiably so, going forward. Now, having said that, I'm going to flip over to Muzu. And you've heard a lot about both the opportunities and the concerns of using AI systems in healthcare. And from a South African context, how do you think what are some of their reflections? And considering the current capacity challenges that many countries are having, that you yourself had talked about previously, what are some opportunities for AI as a catalyst to help contribute to addressing those challenges, but also just contribute to better health outcomes as a whole?
Yeah, no, thank you very much, Eric. Again, I think it's important to understand that in South Africa, the health workforce is really, really under a lot of pressure. So we're talking 0.31 per thousand. So that's the number of doctors you have. You have one doctor for over 3,000 people. So when you look at it from that perspective, AI play a massive role, especially in rural areas, because doctors in South Africa tend to concentrate in the urban area. So there is an opportunity there. But there's also, that's why we're holding this AI roundtable. There's also this feeling that, look, there are challenges within the fiscal space in South Africa, the ability of the state to absorb some of the doctors that are coming out of university, even though there is a need for them to be actually employed. So when you look at it from that point of view, doctors could, in fact, resist, especially if they don't understand the role of AI. They could resist in the use of AI, especially in the public sector. So there is a need for training of doctors to understand AI, that if well integrated, it could actually be used as an augmentation tool for their own work. And I mean, we also now trying to find solutions that could just help these young doctors who are coming out of med school to post their community service, which is almost like after your internship, to plug and play immediately. So when they come out, they could start consulting immediately and not have to set up complex private practice, which needs massive investment in terms of setting up. So those are the things that we're looking to put together as summer, but the resistance will be there, and that's why it's critical for us to have a critical mass of our doctors understanding the fact that this thing you can actually use to have new business models for healthcare delivery. Yeah, but the concerns are there, and I mean I cannot agree more with Jesse. One of the major concerns in the medical field in South Africa is the lack of that regulatory framework. Massive concern for doctors, that because the leaders in that space also in the main are not clinical in South Africa. So that's why we talk about the need for clinical leadership to emerge there, so that we can have an environment that is grounded on ethics. I'll stop there.
Yeah, that is fantastic. There's a lot of reflections about the ethical world, but also the practical realities of how to, again, foster trust in this new capability. And actually, I'm going to go to one of the questions in the chat that just came out, that I'm quite curious about. So I'll just read it verbatim, and then invite the panel to reflect on answers and just take an answer one at a time. So is there a parallel to be made between the promising paths linked to AI and those associated with the Industrial Revolution, which promised a leisure society the liberation of humans from work? Let us recall that social inequalities in access to care have widened in recent decades, unlike the period from 1930 to 1980, marked by progressive measures, in particular the prevention of diseases and the less curative environment, and ultimately reflecting that the word inequalities is not in the report. So my question for folks is, are there parallels that we can draw from this AI revolution to prior revolutions like the industrial age? And if so, what lessons could we actually take from that?
I mean, I think the answer is yes. What's happening is, you know, at least in the US and I don't know globally, we have very complex systems that have grown up over, you know, decades, hundreds of years, that are not high performing. And, you know, the likelihood that I will walk into an operating room on Monday and have the same team doing the same thing is actually infinitesimally small, because we have 300 nurses, we have 150 surgeons, there are 200 anesthesiologists. And so all of the complexity of the systems, at least, you know, in the US, drive challenges around reliability. And I actually think one of the most important roles that AI-enabled tools are going to help us with is to improve the reliability of the systems that we work in that deliver care. And that's actually where I think we're going to get so much opportunity to really improve outcomes, drive down costs, is because when we forget to do things, when there are system errors because of the complexities, that's when patients suffer. And so while the work will change, how we work will change, I think one of the most important attributes of the revolution that's hitting us is going to be the ability to really backstop the reliability of the system that has been very, very difficult to chase down.
Thank you for that. Does anybody else want to take a crack at that question? Giovanni.
I can draw one parallel with one example that comes from 1950s is the microwave. Actually, in the 50s, the microwave was designed to to let women at home spend less time cooking. Okay, And once it was deployed in the United States, instead of taking back time and giving back time to women, it actually 8 more hours per week were spent during chores. Why am I talking about this and drawing this parallel? It is because AI is said to potentially give back 30–40% of time with the medical doctors, but to do what? And if we do not prepare enough in what giving back time will actually mean in clinical practice, then we are in for big surprises.
I would say that it is definitely a revolution, and a magnitude of a revolution maybe that is comparable to the Industrial Revolution. And the lesson that I can take is that we are, in looking forward, we will find new things, new challenges that I think we can't appreciate now. And we have to follow this carefully. The work of physicians will change, the way patients are looking involved or, in their treatment is changing. I'm not sure that I know everything about what's going to happen and how to deal with that. And we must follow it carefully.
I think for developing economies like ours, I think there's a massive opportunity for folks that do not have access to medical doctors. I mean, now you can literally connect a central hospital to a rural clinic. And you can advise the nurses sitting in a central hospital. So where you have scarcity in terms of specialized skills, there's a massive opportunity here for developing economy. And I think, of course, those needs to be weighed. That is why it's critical that we need to have the framework that governs this, so that we can leverage and learn in the process, So for me, I think, yes, the risks are there, but I think there's an opportunity here for our sector. I really think so.
Excellent, excellent. So, as much as there are many challenges, there are also opportunities. And one of the questions in the Q&A was reflecting on Giovanni's earlier point, asking about financing. May I ask the panel members their views on the barriers that exist to getting AI solutions into the market for use by healthcare providers, and what enablers need to be in place to smooth the way for good AI solutions into the market? Is developing financing an issue? So I think we've heard some of that in terms of the regulation and the proof points around that, but other points.
I won't harp on the financing, how stuff gets paid for and validated and all of that. But a related issue is liability. And we are struggling in the US to figure out the liability framework for when a clinician, physician, healthcare worker uses an AI tool and something goes horribly wrong and a patient is harmed, who is liable for that? Should it be the software developer? Should it be the system implementer? Should it be the end user? I think that's going to be a very big challenge for us as well as globally. And there are policy proposals in the US that would have all of the liability fall on the end user, which we do not think makes sense. We don't think it comports with traditionally how we think about medical legal liability. But understanding that issue is going to be really important, because if I am afraid that a developer, maybe their tool was miscalibrated and I use it and I am stuck with all of the liability if a patient is harmed, then we think that will be the end of the market for the use of these tools. We don't want that to happen. So the liability question, we think, is as important as the foundational financing question.
And actually, I'm going to interject, but then ask Nachman or others to reply too, because there are two other related questions in the chat to that point. What about the impact of research and algorithm bias in developing nations or non-Caucasian populations? Because the vast majority of the world's data comes from westernized societies. And then reflecting exactly what you just said, Jesse, there are no clear parameters to measure reliability or efficacy of these tools, especially when they're used in diagnosis and treatment. Shouldn't we be approaching their use as being used on a trial basis with all ethical oversight and precautions as this entails? So, with all those additional points, I put it to you and others.
I mean, I can interject here.
Yeah.
Well, bias is one of the points in AI development that is actually being approached in a too well-thinking way. What do I mean by that is that sometimes bias in AI is a good thing when it comes to health. Consider this, for instance. I am a psychiatrist and I see pretty severe patients in my clinical practice. Standard models that might be developed into inclusive, but say over well-represented samples might not apply to my population. My population needs biased models. And this is what I always say, is that bias can actually be used in artificial intelligence as a good thing when it's actually thought through. It is not really bias the problem in artificial intelligence. It is AI design. And it's the methods that are underlying the models and who produces them and how do they evaluate them. Circling back to the question about performance measures, yes, performance measures exist in silico only. We can predict based on the data, on the data set, how an AI model will perform in clinical practice. But that is just in silico. Actually, the true performance will be underlying how will the model be implemented in clinical practice and how the actual patient care level will be augmented. And this is why I partially agree with the question around measures, is that we do have measures, but current legislation and lawmaking is not sufficient enough to cover medical doctors with this. For instance, the European AI Act kind of pushes vendors into providing performance metrics for artificial intelligence models, but does not specify validations models that are kind of agreed upon to achieve these performance metrics. What does it mean? It means that, say, an AI solutions might obtain performance metrics based on a simple cross-validation, but they do have checked the box and they can provide the model and sell them. So further reflections and thinking are necessary when it comes to AI adoption, especially with concerns to metrics and yes, bias.
Yeah, no, I think history can attest that vulnerable communities have been a victim of studies that are done outside of their own and then just translocated into those communities. And I mean, this is one of the reasons why we think that we can work with our global partners, but it would have to be almost something that is done here for our own population, because there's just no way. I mean, I was in Taiwan at the beginning of this year, and they were demonstrating to us some of the work that they've done in pancreatic cancer, which is a major issue here in South Africa. But the machine learning, the training of those models, you can take that information, that data from Taiwan, and translocate to another setting. So it would have to be South African data or African data that can then be used as a solution here. So for me, I think much as there are opportunities, we just need to be be very cautious in terms of how these things, so that we don't repeat some of the historic atrocities that have happened in the past. So I think much as we're looking for solutions, but we also want to generate some of the solutions here, working with our global partners, so that we don't put our people, because we say they are vulnerable. I mean, I made an example about rural community, but I mean, that would be just helping out the nurse who is in a rural setup and doesn't have access to a doctor, but not using a tool, an AI, a machine in a clinical setting that would have been developed, I don't know, with data from outside of our country, for an example. So those things are very, very important.
Okay, continuing with this point, definitely when you take an application that was trained and built outside your system, you have to check it on your patients, on your system. The point is that I don't think we have a methodology for that, and it also needs to put many efforts and resources to do such things. So that leads to the idea that the adoption of tools that are built outside your country or outside the kind of patients that you treat, you won't adopt them. And this is another issue. And especially it's important for developing countries, because many tools will be developed in Western countries, US, Europe, and how can we transfer this technology to the developing countries? Some of the things can be done from far away, but implementing these tools in developing countries is really a challenge. And I would like to say a sentence about liability. I really agree with you said that this is a huge challenge. But on the other way, I would like you to ask you, Jesse, what's the experience in the US with decision support systems until now? It's a kind, maybe it's less problematic than AI, but we can compare. I don't remember in Israel that we had a lot of issues around it.
Yeah, no, I mean, I think it's a related framework, and it's always been clear. The manufacturers of the companies, electronic health records, other systems have been very clear throughout the advent of advanced clinical decision support systems that they're not making a medical decision. They're not providing a diagnosis. It is supportive information, a nudge, a reminder, something you might want to look at that's used as a part of the care delivery process. When you start bringing AI tools in, that there's a different set of reliance or diagnostic capabilities, the equation changes. And that's where I think we need to make sure that we have a clear understanding of how that interacts with this liability question.
Thank you. It's always fantastic when the panelists start asking questions of other panelists. More fun that way. Actually, I wanted to build on one of the things that Muzu was just talking about a few seconds ago about collaboration and partnerships, because it relates again to one of the questions in the chat. As you are all involved in this work from your many areas, we're actually literally a representation from 4 different continents on this call. So what types of partnerships are already existing or are forming between hospitals, healthcare systems, private sector, public sector, universities that are bringing together the engineering programs, the law schools, the medical and nursing schools to tackle these core issues of AI and health in a more integrated and collaborative manner?
I'll tell you, Eric, we have, I think, sarcastically, too many coalitions, alliances, versions of groups, multi-stakeholder coming together to try to create their version of the future. I had a spreadsheet tracking the US versions, and I stopped when I got to 18 of them. And I get it. We do need this activity to happen. The challenge is that there's 20 various different versions of kind of the same thing. And I'm not really sure that that's helping us advance the conversation in a meaningful kind of way. We do need to solve a lot of issues. If the US had an integrated data platform where we could look at performance of algorithms at scale across delivery systems, we'd be in a very, very different place from a performance monitoring validation standpoint than we are today. So how do we deal with that, given that that's not the infrastructure? That's very different in many other countries where you do have integrated data platforms or universal records where you can actually see what performance looks like, which changes the validation equation over time. And then what does that look like globally, particularly with the data privacy issues and challenges? I don't think anybody really has a clear answer to
that. If I can add upon that, so Belgium has a strong track record of different coalitions and ecosystems that have been built at different levels. It's quite amazing. You have ecosystems that surround the healthcare sector and the pharmaceutical sector. You have ecosystems that surround the healthcare sector with the technological sectors. Depending on the funding system, we have 7 to 8 ecosystems that are of equal importance to Belgium alone and that interact with different other countries. Second, let's not forget that Europe is a head start, ahead in this with the European health data space. Belgium is a kind of a good student in that because we have now funded from many months now our health data agency that is actually enacting what Jesse was just talking about a few moments ago as a common data model to share data across Europe, which is kind of an amazing initiative. And we are starting to see now the fruits of this vision and this collaboration ecosystem. This is, of course, for the ecosystems that surround healthcare and other fields as well. And therefore, secondary use of health data is, of course, the backbone of these kind of collaboration. Data has value, and every stakeholder is interested in gathering the value that they can from the actual healthcare data. And it is actually cross-collaboration with different fields and different sectors that is bringing us to a whole new level. I'm quite happy about that, although many steps are still needed.
So in our setting, especially in the private sector, I think the hospital groups have actually come together and they've got some interoperability and they're starting to share data. And this is one of the reasons why we're pushing government to actually work with them and create that public-private partnership so that we can have a database for all South Africans that is centralized. That when you go between systems, you don't have to struggle, because at the moment, if you're not within the bigger groups within the private sector, your data might not be available for your practitioner. So and that helps also in precision medicine. So we're trying to talk to the minister to push for that. And I think if we are to achieve what we're setting ourselves to in South Africa of universal health coverage, we're probably going to need to have more partnerships. And I think as an association, I'm at least proud to say that we've got 2 MOUs with, I think it's the UAB, the University of Alabama in Birmingham, that we've partnered with them as one of our partners in content provision, so that we can roll out training for our doctors here in South Africa to demystify AI. And we've also partnered with, I think it's the International Cooperation Fund in Taiwan, also to try and make sure that we do get doctors being trained as fellows in this thing so that they can come back and lead in that space.
I would say that AI leveraged the collaboration between the private sector and the public sector, and there are many projects and pilots that are done with IT companies and startup companies and HMOs and hospitals. But the challenge is taking it from a project or pilot to the using large in the whole system. This is a big obstacle, and actually, there are very few, if any, such examples that a pilot was such a success that can be used by the whole healthcare system, by whole organizations. There are many reasons for that. Mainly, I think that there is a financial barrier to do that, and also technological when the systems are used in different organizations are different. There is no one system in Israel, so you must and the standards are not good enough in order to do it easily. So we are working on that.
And I think all of those comments are fantastic. I reflecting on what you said earlier on, Jesse, about there being too many coalitions. I have experienced that myself, and the way that I put it is that we are at risk right now of creating more noise than signal. And that signal, per what you were just saying, Nachman, that the ability to scale solutions responsibly, ethically, and equitably is absolutely imperative. If we keep on doing AI in the same way we did the digital age, we're at risk of expanding digital divides. So, even further than they already are. But with that, I'm going to move into the last bit here with folks. So I'm warning each of the panelists that I'll ask you for one remark in turn. Like in 1 minute, what would you summarize in terms of your findings? Before I do that, because I'm giving you a moment to think, collect your thoughts in that space. I wanted to thank everyone. We've heard a lot about the fact that the nature of work is shifting. There was a lot of work around AI being done around as a backstop and a verification tool, and it's emerging as a clinical tool, but that change requires clinical leadership. The change is real. 1 in 5 doctors are using it in the US, but we need to worry about education, and education is key. And the inspiration from Belgium that type of education is in fact mandatory is fantastic. But we need to do so in a way where we are doing it with the public, with providers, because the shift will happen at the speed of trust. And we need to be thinking about things in a longer term vision rather than short term spurts. This is something that requires scale, time, patience in order to achieve. And one last thing I'll say, just because I found it funny when I was scribbling my notes, bias is not a 4-letter word, even though it is a 4-letter word, because bias is entirely about in the context in which the algorithms are actually used. So I thought that was actually a really important point to bring up. Anyway, so those are some of my insights that I got in the last little while. But I'm curious, so I'll start with you, Giovanni, and just what are your reflections in a minute?
So as I only get 1 minute, I would say that we live in the era in which now strong political visions around AI and health are now necessary. We cannot content ourselves with a couple of paragraphs in national policies that concern AI, leaving wide open the fields of what is possible. And to me, a strong political vision for AI must include that AI should be developed in the following 5 axes. The first is improving the quality of care. The second is to improve quality of life at work and efficiency of medical professionals. Third is to support institutions in their day-to-day life, and I mean logistics and whatever. Fourth is to support research and development through AI tools that can help us discover new models, discover new drugs, discover new things that we can do in medicine. And five, support public health policies, because I think that AI is really important for public health policies. And nowadays, we're not using the 10th of its power to do that. And that's it for me.
Muzu, what are your thoughts?
So I think what's comforting for me, and I think for the association, especially from the findings of the paper, is that doctors are not rejecting AI. They're just calling for co-creation, that it's not developed without them. So that's comforting. And I think from a developing economy point of view, I think the opportunities exist for us to leverage that. But I think what would be critical for South Africa in the development of AI is, as I indicated earlier on, strong clinical leadership. I think that's fundamental for our country. And I think we're rooted in ethics so that we are very clear in terms of who takes responsibility when things go wrong. I think that would be fundamental for us. So thank you very much, and I really appreciate it.
Thank you for that, Mr. Jesse.
Well, thanks. This has been a really fun conversation. There's obviously a lot to unpack, and I hope that we can continue to find ways to engage in the policy work that needs to happen to harmonize what's happening at a global level. I will say one opportunity that we didn't get into too much that I think could be really helpful is around labeling, right? So what goes into the label that is associated with a digital tool, an algorithm, or some other AI-enabled product? I think that we're struggling to figure that out in the US. Obviously, I spoke about transparency, and labeling is one way to deal with that. But you could imagine the power of some universal labeling approaches and frameworks across the globe being very helpful as we're trying to navigate having safe and effective tools for patients globally.
Amazing. And I will give you, Nachman, the last word as the author. It makes sense that you bookend.
Thank you, Eric. Well, we spoke a lot about the impacts of AI on the workforce, but I would like to raise another concern. I'm afraid that it might be that we won't achieve one of the most important goals of AI tools, reducing burden and burnout of caregivers. Why do I am saying this? Because when I'm looking at the implementation of the EMR in healthcare, and when we did it, we hoped to reduce the burden, and now we speak about the place of EMR in burnout. What causes burnout to physicians, and EMR is accused for that as well. So I hope that we will learn from that, and I really hope that AI will achieve the goal of reducing burden, and not that we won't find in 10 years or something that we did something wrong that added burden.
Absolutely. From the OECD's perspective, we see a deficit of 3 million health providers. AI can contribute to that, but a big part of that deficit of health workers are not just the fact that bringing people into the workforce, but burning people out of the current workforce. And we want to make sure that we're measuring the effectiveness and satisfaction of providers with these new tools, because people who use AI on a consistent basis, my experience, love it, and they wouldn't do without it. And so how can we bring that type of joy experience to providers? And I think a lot of that reflects on, as we've heard from everyone, the need for clinical leadership. And as we've heard, this is about how do we make sure the health providers don't have AI done to them, but AI rather is done with them. And I think that that is my key message to share with people around this. Thank you to everyone in the panel. Thank you to everyone who's been attending our chat today. Thank you, Stefano, for making the opening remarks. And I hope you all have a wonderful remainder of your Fridays wherever you are around the world. Thank you so much.
Thank you very much, Eric.